Himanshi, we can start.
Yes, sir.
Good evening, everyone. It's 7, so let's start the second part of the 7th masterclass. For those of you who are joining today for the first time and did not join yesterday, Jaipur Surgical Tutorial is an online education portal which we have been running for the last more than 2.5 years. This is managed by my colleague, Dr. Anand Nagar, who's an associate professor of HPB surgery at my new institution, the Mahatma Gandhi Medical College Hospital in Jaipur in Rajasthan. And we conduct a session every Saturday, 9 to 10 a.m. Indian time. I will, in between the sessions, post the information how to join Jaipur Surgical Tutorial. In addition, we've also started a special class on Friday afternoon, 3 to 4 p.m. on the request of colleagues from Africa because they could not join on Saturday morning. So that also I will put the information as to how to join that. And we, a few months ago, decided that we will try to cover a single theme, a single topic in a masterclass, which usually runs for 2 days. Usually it's Thursday, Friday, but this time because Friday is a national holiday for us in India, we are doing it on Wednesday, Thursday, 7 to 9 p.m. We've already conducted 6 masterclasses. All those videos are available on the net, on the YouTube channel. Again, the link will be provided once you join any of these groups. And the theme for this 7th masterclass is bile duct injury. Only the acute bile duct injury, not the established biliary stricture. So we are dealing only with bile duct injury. We covered some topics yesterday, and there are a few more topics to be covered today. The moderators for today's session are two very important people. Dr. Mohammad Ibrarullah, who is the second batch MCH alumnus from SGPGI Lucknow. He is now a senior consultant at Apollo Hospitals in Bhubaneswar. But I think his credentials for being on this masterclass as a moderator is that he, along with Dr. Sikora, has published an excellent, very well and very heavily illustrated atlas of safe cholecystectomy. It's a very expensive book, but I would urge all surgical colleagues that if possible, ask your department, ask your institution to get a copy. It covers all aspects of how to keep a cholecystectomy safe. And the second moderator for today is my former colleague from SGPGI Lucknow, Dr. Anu Behari, one of the most scientific, compassionate and safe surgeons that I have worked with. And she's also very passionate about keeping the cholecystectomy safe and the problem of bile duct injury. So with that introduction, I'll hand over to Ibrar and Anu. Ibrar?
Yes, sir. Hi, good evening, everybody. So I suppose we can start right away with the first topic, that is when to suspect a bile leak after cholecystectomy, particularly when there is no drain. So it's basically all a clinical suspicion, and everything has to be based on your clinical suspicion and your, intuitiveness and all that. So this will be by Dr. Kailash Kurdia. Suppose he's from Jaipur only, from your center, Dr. Kapoor. No?
No. Kailash
He's
is
from PGI
our
Chandigarh.
former student from SGPGI. He then went on to PGI Chandigarh.
Yeah, he's presently in PGI Chandigarh, right?
He's currently the assistant professor at AIIMS New Delhi with the AIIMS group. Actually, Kailash had a personal tragedy at home, so he's currently traveling. But he has sent his presentation to me, which he had prepared. So I will replace him. I'll try to do justice to the topic using his presentation, which he had prepared and sent to me. So I'll do it on his behalf.
Right, sir.
Okay. So are my slides there?
Yeah, you can see.
Okay. So before I start, I would also like to welcome Dr. Sikora, who moderated yesterday's session, and Dr. Sadaf, who is the chief of GI surgery at SKIMS, and Dr. Abhinav Sharma, who is a senior gastroenterologist, medical gastroenterologist in Jaipur. He's also an SGPGI alumnus, and he's one of the panelists today. He was there yesterday to make some comments about endoscopic management also. So this is the presentation prepared by Kailash. When to suspect a bile leak after cholecystectomy, and as is usually the case, we don't leave a drain unless we anticipate a problem. Most of us do not routinely place a drain. So we have a patient who has undergone a lap chole. There is no drain. Now the issue is when to suspect a bile duct injury. And all my colleagues who are either attending or will watch this video, we have to remember that it's a peculiar problem with lap chole that majority of the injuries are not detected or even suspected during the cholecystectomy. They are suspected or diagnosed after the cholecystectomy, in the post-operative period or in the follow-up. And this is in each and every report, this holds true, except the group which uses routine intraoperative cholangiography, which is not the practice in most centers. So we have to keep it in mind that the fact that you thought that the cholecystectomy went on well does not mean that there is no problem. You have to keep a very high index of suspicion in the early postoperative period, after discharge, and in the follow-up also. So the issue here, which Kailash wanted to highlight, was that since it has become a routine, since almost everybody is now doing laparoscopic cholecystectomy with better and better anesthesia and perioperative care, the recovery is getting even better and faster. And therefore, many groups are now practicing lap chole as a daycare surgery. Patient comes in the morning, goes home in the evening, doesn't even stay overnight. Although I personally prefer, and it has been our practice, that we keep the patient at least for one night in the hospital. The only exception, Anu would remember, we have made is a young lady who has a small child who's breastfeeding. And if these are the cases which we post very early in the morning, first case, and if there is good, complete, full, satisfactory recovery, we may allow her to go home in the evening so that she can look after her young child, and insist that she comes back to the hospital the next morning to have a routine checkup as if she was in the hospital. So that is the only exception. But I know that many centers are now practicing lap chole as a daycare surgery. Now, this is one report which Kailash has cited, that they found that as many as 80% of cases were suitable, and out of this, 96% could be discharged the same evening. But 3% did require readmission within 48 hours or after 48 hours. And a small number of cases required re-intervention also, although there is no comparison here. But what he has tried to say, that even in our own country, and this is a report from the base hospital in Delhi, that lap chole is being done as a daycare surgery. This is another report from PGI Chandigarh, where the percentages are less. And they said that if you practice it as a daycare surgery, you have to be extra cautious. You have to give clear instructions to the patient. The patient has to understand them. The patient should be ready to come back if and when there is a problem. And you should have a system that if the patient comes back, the patient is attended to quickly. Again, I would cite an instance where we did a lap chole at SCPGI in a young man who had no comorbidities. He went home. This was not daycare. This was routine one-night stay. He came back with some vague, non-specific symptoms to the emergency. The emergency team saw him, and they did not suspect or they did not understand the gravity of the situation, gave him some symptomatic treatment and sent him back home. Now the patient was reassured that doctors have seen me, everything is fine, nothing major problem is there. But the problem continued and he returned after 2 or 3 days. And by that time, the patient had developed severe systemic sepsis because there was some bile leak and went into irreversible multiple organ failure. In spite of a re-intervention done by us, we could not save this patient. And this patient, I don't think I would forget throughout my life and maybe after my life also, because this was completely avoidable outcome if the patient had been seen by a member of our team when on the first day he came to the emergency. So one has to be very, very careful when you practice a daycare lab chole. Now, what do we expect after a lab chole, especially? On the evening of the operation, if it was done as the first case, but if it is later, then at least by next morning, the patient should look well. I always tell my students that when you go and see a patient next morning in your morning round after a lab chole, the patient should say hello, namaste, or whatever to you. She should be sitting up in the bed and she should look like as if she is a pre-operative patient. That is what we expect after a lab chole. She may have some nausea and some pain, depending on the sensitivity of the patient, but it should not be so severe that it requires injectable. Either she should be able to tolerate it, or maximum, you may have to give some oral medication which should relieve it. She should have taken a cup of tea, maybe a few biscuits. She should have gone to the toilet and passed urine on her own, which means that she's out of bed. And she should be asking you, doctor, can I go home? That is what is expected after an uncomplicated lab chole in a otherwise healthy, fit patient who has no severe comorbidity. But does this happen? And why it does not happen? It does not happen because of bile leak. Now, yesterday also we discussed that in some classifications, a bile leak from the cystic duct, from the cholecystohepatic duct, or from a small aberrant duct may be classified as a minor injury. Actually, in my opinion, there is no entity like a minor injury. Injuries are injuries. The duct may be minor, but the injury is not minor because the consequence is same. Consequence is not because of injury per se, consequence is because of the bile leak. And the incidence of bile leak, if you look at reports from all over the world, ranges from 0.5 to, if you look at data from countries where there is a prospective mandatory audit, it is even more than 1%. And this percentage has not changed overall over a period of time. So now lab chole has become part of surgical training, but still bile leak continues to be there. So it is an inherent problem of the procedure per se. Now, this is a very old report, 1989, and it shows that when routinely an isotope scan was done, a significant number of patients had bile leak. It may not have resulted in a consequence, but it is there, it is common. So there is no reason why that would have changed. And this is the report which says, this is again an old report, that the incidence at this time was the same, 1%. And the commonest manifestations were pain, fever, and tenderness. But note the point, the duration of interval between cholecystectomy and presentation, 5 days, which means the patient is at home. Patient is not in the hospital because we don't keep these patients for 5 days. So what I'm trying to say that even if the patient has gone home on day one without any problems, it doesn't guarantee, it doesn't mean that there is no problem. There could still be a problem. Patient may develop symptoms later. And this is a very large report, a collective kind of experience, which again shows that bile leak and bile duct injury rates are to the tune of 0.4 to 0.5%, which means 1 in 200. 1 in 200 lab colis will have problem, and these are the various sites from where bile leak can occur. Now, bile in the peritoneal cavity behaves in a very erratic fashion. We all have seen patients with litters of bile in the peritoneal cavity, biliary ascites, and roaming around in the OPD with no sepsis. On the other hand, even small amount of bile in the peritoneal cavity can cause havoc. This patient, which I referred to, when we re-explored him after about 4 or 5 days, we didn't find more than 50 or 100 ml of bile in the subhepatic area, but he had gone into severe systemic sepsis. So that is why if you proactively look for bile leaks, you will find them in more patients than you clinically suspect or detect, because many of the small leaks may not cause any problem. And because the duct injured is small, it closes on its own without any consequence. And you don't even know that there was a bile leak. But if there is a significant amount of bile which is leaking out, it can manifest as either a biloma, which is a localized collection of bile, usually in the subhepatic area. But look at the subphrenic area also, look at the left subhepatic area, the lesser sac also, and look at the pelvis also when you are doing an ultrasound. Bile ascites, which is bile in the entire peritoneal cavity, free bile, or with or without sepsis. So bile ascites or bile peritonitis. And then, of course, if you have a drain or if you place a percutaneous drain, it becomes a fistula, which is controlled. But if it comes out through the port side, it becomes an uncontrolled biliary fistula. Biloma is the commonest manifestation, but the most serious is biliary peritonitis. Biloma would cause sepsis, but it may not cause systemic sepsis, whereas bile peritonitis will usually cause systemic sepsis and multiple organ failure. So the range is from asymptomatic bile ascites or biloma to fatal lethal biliary peritonitis, and it depends on amount, on the presence or absence of bactobilia, and as I said, an individual variation depending on the immune response or the body response of the patient. Any untoward, unexpected symptom in the post-operative period is an indicator or at least a suspicion of bile leak unless proved otherwise, which means that if the recovery is not as expected as I described earlier, one should think that there is something wrong. And something wrong after lab chole is bile leak unless proved otherwise. There could be other complications also. There could be bleed, there could be a duodenal injury, there could be colonic injury, but we must first think of bile leak. And if we investigate for bile leak, the other injuries also we will find. So if the patient has unusual pain, which is out of proportion to what your other patients have had and which is requiring injectables even on the next morning, or if the patient is having so much of anorexia and nausea that she doesn't even want to drink a cup of tea, she's not comfortable, she's tossing around in the bed, you need to think that there is something wrong. So again, the statement that if the patient doesn't feel well, doesn't wish to get out of the bed, does not eat or does not wish to go home, you need to suspect a bile duct injury or bile leak. If there is any abdominal finding on examination, because on the following day, the abdomen should be completely soft, non-distended, non-tender with normal bowel activity. If the abdomen is distended, if it is tense, if it is tender, if the sounds are less than what normally they should be, there is something wrong. If the patient has any tachycardia, tachypnea, fever, hypoxemia, and if you do a complete blood count, any leukocytosis, then again, there is something wrong. And I would repeat, something wrong means bile leak unless proved otherwise. So any variation, any deviation from the expected post-operative course should make you suspect that there is something wrong. And the problem is compounded because we, unfortunately, and that should not happen, tend to take lap chole lightly. Because we have so many other patients, we give less attention, unintentionally, of course, to a patient who has had lap chole, thinking that everything would be and should be and is all right. And the patient is not observed properly as it should be before or after the discharge, as compared to another patient who has undergone a major operation. So my request is that lap chole has to be taken as seriously, and I would say even more seriously than a patient who has undergone a major operation, because after a major operation, everybody is attending, everybody is attentive, everybody is careful. These are the patients in whom, if you have a slightly, I wouldn't say careless, but not very careful approach, you will miss a bile duct injury, which otherwise should have been detected. So again, Kailash has quoted a report of these patients who had undrained bile collections, and undrained bile collections resulted in serious complications, including sepsis and organ failure. If there is bile in the peritoneal cavity, it has to come out. And therefore, it is very important to find out if there is bile in the peritoneal cavity, because if it is there, it has to be taken out either by percutaneous radiological intervention or by surgical intervention, which could be a re-laparoscopy or laparotomy. But most cases these days do not require surgical intervention, because if you have good radiological support, interventional radiology, it can be done by percutaneous intervention. And there are reports which say that patients who ultimately were found to have these bile collections, initially it was either not suspected or it was discounted. That patient had some problems, but we said, no, 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 you are all right, go home, nothing to be worried. So this is frequently reported in a series of bilomas or bile collections. Again, a report where it is mentioned that as many as 87% of patients, the injury was not recognized during cholecystectomy, and these patients were discharged home without a detection. But retrospectively, it was found that many of these patients had bothersome symptoms, which should have been attended to, which should have been looked into. And a large number of patients in whom a bile collection was detected later, it was found that there were some symptoms which were non-specific, which were insignificant, but they were there. And therefore, any symptom present on day one after lap chole should be followed up, should be investigated while the patient is in the hospital. So again, the same thing, the details of these reports. And the commonest problem is bile leak. Of course, there could be other problems also. There are various reports which say that once the patient has been discharged, because then the patient is not under your observation, these collections are missed, they are detected late, and there are reports saying that even up to 9 or 15 days, these collections remain undetected, because the collection obviously happened during the cholecystectomy. The only exception of a delayed collection is when it is a cautery injury, thermal injury to the bile duct, which doesn't cause bile leak during surgery or in the early post-operative period. It is after 3 days, 5 days, 7 days that the wall sloughs necrosis, and then there is a delayed bile leak. And therefore, it is very important to give instructions to these patients that they must come back at least for one follow-up. And even if they are not coming back for follow-up, if there is any problem, they must come back to you, or at least they should see a surgeon. So Kailash has put some concluding points that symptoms of bile leak or bile collection are very, very subtle. They are usually overlooked, and this is responsible for the delay in diagnosis. And delay in diagnosis is responsible for onset of systemic sepsis, multiple organ failure, and mortality. So we should keep a close watch. We should have a very high index of suspicion of a bile leak after a lap chole. And if the patient is not recovering as smoothly as expected, again and again, I'm repeating this point, this is the most important sign that there is something wrong. Pain and tenderness, the classical signs are found in very small number of patients who ultimately had bile leak. There are non-specific symptoms. And if these collections are diagnosed in time and drained, then we can avoid serious complications of systemic sepsis and multiple organ failure. So this picture he borrowed from me. This is one of my patients who, before we started the ward rounds, we usually stand on the counter and discuss some things, the ward counter. And she came and said, she addressed me as uncle. She said, I want to go home. Can I take a selfie with you? So that is the expected recovery. If it is not there, you should suspect there is something wrong. And again, I would repeat, something wrong after lap chole means bile duct injury, bile leak, unless proved otherwise. Thank you. So as I said, this was the presentation which was prepared by Kailash. Unfortunately, because of a tragedy in the family, he could not be joining. He is still traveling. And then I told him that I'll cover for him. Thank you. Over to Ibrar and Anu.
Yeah. I'll make just a few comments. I think this has been adequately emphasized by Dr. Kapoor, that the first appearance, when you next day, when you go to the rounds, that is where you get the first impression. I mean, what I do is I just look at the face of the, are you ready to go home? And most often they would say yes. Getting up from the bed, that is where you suspect. And the first thing is put your hand on her pulse, his or her pulse. Tachycardia is a very important sign, and that really alarms me. Like, there is probably something wrong before I go on to examining the abdomen and looking the other things and all that. So tachycardia is a very important symptom because fever and all those things would come little later. But first thing that is to appear is a tachycardia that you must not ignore. Any patient post-lap chole first day having tachycardia, then that has to be taken seriously. And then, the rest of the thing has to follow after that. And as regards the course of the behavior of this patient, as I said, it is, as Dr. Kapoor has said, this is very, very unpredictable. In fact, if I have to recall a patient of mine, it was a little difficult cholecystectomy, but 24 hours next day, he was rather, little vague complaint, this and that. Evening, I found there is little bile in the drain. This is, I would say, 24 hours after the surgery, I noticed little bile in the drain. Yet the patient was comfortable, mild tachycardia. So I said, in any case, he has a drain, so let me defer the management till next day. By 36 hours, he was febrile, showing all signs of sepsis. Then obviously I took him for, what is that? ERCP and a re-exploration, not exactly, it's a re-laparoscopy where there was a lot of bile collection in the abdomen despite the drain. That was all drained, did a ERCP stenting. But then after that, he never recovered. In the next 12 hours, he had gone into ventilator. And by next day, we lost him. So that is how it behaves. Like within 48 hours, the patient was no more, despite the fact that we intervened after 36 hours. It was not that late, or we did not really ignore his signs and all that. But all the same, you have to do whatever you can do, your best in these situations. So that is that. Anu, I think.
Anu,
Yeah.
any comments?
Yes, sir. I mean, I think there is really, we need to stress this. Lab chole suffers from, what we call familiarity breeds contempt kind of thing. We take it really lightly sometimes. And as Dr. Abrar has also shared, sometimes even when you know, like you've seen a little bile leak, but you think, okay, there is a drain, we can never be complacent. And it is better to overdo in terms of investigation than under. So I think this point, which is, and that is why I think it appeared as a repetition, but it is important for that repetition that no undue symptom, like anything, a minor deviation from the expected post-op course should definitely put us on high alert, and we should do everything. And I think Dr. Sadaf will cover that in the next, as to once you start suspecting, what should you do?
I think before we invite Dr. Sadaf, may I ask you this quick question? Like, what are the situations where you would like to put a drain after cholecystectomy? Rather than, most of us won't do it, but there are situations where we would want to put a drain. So, Dr. Kapoor, can you please just...
Yeah, if it is not a simple gallbladder, if I suspect or anticipate that there is going to be a problem, I would over react and place a drain. So all partial cholecystectomies must be drained, because there is now evidence also that if you're doing a subtotal cholecystectomy, the incidence of post-operative bile leak can be as high as 10 to 15%. So all subtotal cholecystectomies must have a drain. A difficult gallbladder, where you are not happy with the clipping or suture ligature or stapling, whatever you have done, it is better to put a drain. If during surgery, as we discussed yesterday, not in the Kailash triangle, because that indicates a main ductal problem. If in the gallbladder bed dissection, you found that there was some bile and you either controlled it with a clip or you took a suture there, then again, it is better to leave a drain, because it is likely that you may have a continuing bile leak in the post-operative period. A very inflamed cystic duct, especially if you are operating on acute cholecystitis, the inflammatory edema, if you use a titanium clip, it can go through the edematous tissue and result in a bile leak. If you are using a hemolock, and once the edema subsides, because now the offending agent, the stones have been removed, the clip may become loose and there could be bile leak. So in that situation also, I would definitely prefer to leave a drain. So if there is any anticipation of a problem, it is better to leave a drain, because if you don't see any bile the next morning, you can remove it and the patient can go home as per plan.
Yeah, another quick point, before we move on to the next speaker, is about this subclinical bile leak. Dr. Kapoor, you quoted a study where earlier, there's a pre-lab college study where the incidence is up to the tune of, I think, 20 to 30%. But we also did a study, and I don't exactly remember the percentage, but I don't think it was that high.
No.
Yeah, so probably I think the earlier study was flawed.
I think it was just an isolated study which Kailash, but I think the idea Kailash must have in mind is to highlight the fact that even in that era, even in open chole era, bile leaks were frequent. And yes, many of these bile leaks may not be clinically important or relevant or significant, but we need to be looking for them. And
could you remember what was the incidence we found in our study? I don't really.
No, it was way back when you were there.
Yeah, that was in World Journal of Surgery.
Years.
We published that, yes.
Yes.
But suddenly it was in single digits, suddenly not.
We still have 5 minutes. So if any of the other panelists, I think Sadiq has raised his hand. Sadiq? No, sorry. So any other panelists would like to make any comment on this topic, how to suspect, because this is the most important part of the whole scenario of bile duct injury before we move on to Sadaf. Yeah, Sadiq.
Good evening, everyone. Thank you. Now, I just want to, apart from all the important things which have been highlighted, one of the things I always say is, of course, in all patients, but specifically, especially in a group or when they're residents, they should be aware of how the cholecystectomy went. That means, was it a difficult cholecystectomy? Was there any issue during the cholecystectomy? How was the gallbladder? This information is preloaded in your mind when you are looking at the patient the next morning, and where there is an increased suspicion of problem, and that patient, if the patient is not doing well, you certainly double your suspicion for a possibility of a bile leak and collection in those. So that is an additional this thing. And about drain, I just want to say that we've all the points or indications which you said, but now we are going away from putting drain in most, except when we are doing a subtotal cholecystectomy. But if you suspect that there was a problem or like edematous tissues and all, then of course you should not hesitate to put a drain. But I think since drains are getting off as a routine, the clinical assessment of the patient becomes very important before you plan for a discharge for these patients. And you both have highlighted cases where there is a sudden deterioration of these patients having missed a clinical scenario.
And sir, I was remembering what you had said about reviewing the recording if you have. So this comes to mind always whenever a patient is not having the usual course and all. And if like you were not there at the time of surgery, especially, so, apart from asking as to how it was, this visiting the recording is also very important for this also. Like,
Himanshi, Dr. Anand Nagar has joined. He says that on YouTube, there is no audio. So can you please check whether the problem is at our end or is it at the YouTube end? Anand, you can put your video on so that I can introduce you again. Anand is my colleague, as I mentioned earlier. He is the one who's been managing the Jaipur surgical tutorial for last almost 2.5 years.
Good evening, sir. Good evening, respected speakers also.
Right.
Sadaf, any comment on this topic before you go on to your topic?
Yes, I had to make a little comment because our audience is for safe cholecystectomy and for beginners. I would like to say that you do not put a drain, is we are talking in terms of people who are masters in the subject. But we would put a word of caution, other than most of us are not putting it. Like our subset of patients are all high risk cholecystectomy. We put it in most of the patients, and the beginners who have just qualified, and they are the bigger chunks of doers of lab chole in bigger numbers. I think genuinely they can put drain in initial phase of their career.
Ibrar, please continue. Anu, please continue.
So now I would like to invite Dr. Sadaf to give the next talk on what to do once we suspect that the patient might have a bile leak. Dr. Sadaf.
So once again, a very good evening to all. And I don't know, my slides are being seen?
Yes, yes. Go to the first slide, please. Yeah.
Yeah.
Yes.
So I would like to thank the organizers to make me a part of the team of today's theme of bile duct injury. And I have been asked to talk about post-cholecystectomy bile leak injuries, how to investigate exactly. And I would like to convey that investigating a bile duct injury is a part of managing bile duct injury. So there's likely to be some overlap, and we have otherwise not touched it in post-op bile duct leaks in the other discussions. And to me, the investigation and management is a multidisciplinary approach, as it is for all of us, because a post-op leak may be a fistula representing minor leak as a cause of cystic duct blowout, to a major leak, which would be from a complex injury, rapidly structuring hilar disconnections with vascular injury. So it can never be a story from one OT where it happened to where it was repaired. It involves many more people, your radiologist, your medical gastroenterologist, your surgeon specialist, the whole lot chunk of the laparoscopic general surgeons who refer you the patient should also be aware of how to manage it in initial phases and should participate subsequently. So multiple factors actually dictate the subsequent investigations to be done. First is, where did the injury happen? Because this gives you a gross idea what were the levels of the hospital where the cholecystectomy was done. Is the operating surgeon actually suspecting a problem? When did she refer the patient? Time since the injury? What is the clinical condition of the patient at arrival? Is there a drain in place or no drain? Is there any obvious bile leak in the drain? What is the quantum of bile leak? And what information did you gather from the surgeon and the procedure recording if you have one? So it is a clinical presentation of the patient which dictates the investigations to be done, as well as how the investigation should be sequenced. The patient may be unstable with symptomatic fever, tender abdomen, raised counts, hypotension, no drain, drain removed, not draining. In case of uncontrolled fistula, and the patient is likely to be stable or leak coming out with not much signs and symptoms, if there was a drain. If there was no drain, then you have to have a high index of suspicion, and it has been already discussed. And in uncontrolled fistula, the patient may be sick to stable as well. Now, what would be the initial investigation? All patients are to be subject to a liver function test, a kidney function test, and a CBC, basically. A liver function test is going to give a lot of information about the patient, whether there is already incoming EHBO after the injury, whether there is significant transaminitis to anticipate a vascular injury, a major vascular injury, or whether there is mild transaminitis due to some amount of leak absorption, the kind of hyperbilirubinemia, the presence of comorbidity. In AKI, your kidney functions may be deteriorating, your counts may be high, you may have thrombocytopenia when there is already sepsis. So much of information comes from your baseline investigation. The second investigation would be an ultrasound abdomen for all patients, which in light of clinical presentation can guide you further. It gives you information regarding the collections. It gives you information where there's already some amount of dilatations occurring and presence of free fluid. But this investigation is operator dependent. Some form of advanced imaging is actually an integral part of managing bile duct injury. The role of imaging in these patients is, first of all, to establish a diagnosis of bile duct injury. Not always when you suspect, it turns out to be bile duct injury. To look into abdominal collections, to delineate the type and extent of injury, and to plan appropriate intervention in these patients. So what you do is you need to take a call between CT scan versus MRCP versus ERCP based on the clinical scenario. In patients with persistent symptoms, nausea, vomiting, fever, distension, you'll go for a CT scan first, following ultrasound. We look for the collections and the abscesses if present. You need to take a lead from concurrent doing of CRP, procalcitonin, lactate in selected patients, and pick up the need of urgent intervention for sepsis control. When there are features of peritonitis with CT showing a diffuse leak or fluid in the abdomen with no localized collection, sometimes in these patients, you need to take them for an immediate damage control surgery. On the other hand, a patient who has collections is comparatively stable, might only need a radiological guided aspiration or pigtail. So we are not doing the part of EHBO, but some patients may have early setting of EHBO with rapidly stricturing ducts, and sometimes the patient may be referred late, and there may be disconnection between the presentation and the present situation, and you might have to rule out malignancy in some patients. So MRCP would be other important investigation, and ERCP. By many in present era, CT is recommended as first investigation. The World Society of Emergency Surgery consensus guidelines published in recent past actually suggest that all patients should undergo CT scan. After stabilization, MRCP, CMRCP should be complementing all patients to classify the kind of injury and tailoring the treatment. And the need of ERCP and PTC should be dictated as per the grade and level of injury, as well as existence of concurrent cholangitis. So the role of CT scan is to look into the collections, the perihepatic fluid, the ascites. It has a very important role in identifying any associated vascular injury. It picks up biliary obstruction with upstream dilatation in cases of long-standing injuries and neglected patients. It can show you the lobar hepatic atrophy in vasculobiliary injury, and a concurrent sign of features of secondary biliary cirrhosis can also be picked up on CT with widening of fissures and nodularities. About vascular injury, if you see don't see from the perspectives of surgeon, if you see from radiological investigatory studies, the incidence is as high as 47%. The commonly injured vessel is the right hepatic artery. Luckily, unusually, this does not lead to significant early complication, but it is likely to pose problems during reconstruction because the injury is likely to be very high once there's an associated vascular injury, and the transverse artery might get injured once you approach that area, and the repair must be difficult. And another important aspect of knowing about vascular injury once you receive the patient is that you will take the anastomosis more seriously, because these patients are likely to have an anastomotic stricture due to ischemia. Their follow-up would also be more vigilant. So these are some images, because the audiences, if they join and see later on the YouTube, how would they pick up the collections and how helpful the CT scan would be. And you can see such situation where somebody has injured both the artery and the vein, and ischemic liver seen, cholangioscopic vasculogram showing there is cutoff of the right-sided blood supply. But there are shortcomings with CT scan. It does not reliably distinguish leaks from the postoperative collection. The patient may have some other kind of collections like blood, pus, serous fluid, and it's not always a bile leak. It cannot distinguish precisely the site of location and the active state of bile leak. The active state might not be important as per managing, but then due to overlapping areas of collection, it is not a good investigation to classify the injury according to the site of the injury. MRCP as such next is a gold standard investigation. It gives you a complete morphological evaluation of the biliary tree. It offers you a detailed information about the integrity of the tract, where exactly how much it is disconnected. Its yield can be enhanced by doing a CMRCP by using contrast agents. It can be more informative than the conventional MRCP. It actually allows you to detect active bile leak or extravasation into the fluid collections in delayed T1 post-contrast images. It gives you the site of image, type of leakage and type of injury with accuracy, and it shows you whether the fluid collection is a bilium or not based on the signal void intensity, like that of bile presenting as low signals in T1 weighted images. There are many radiologically oriented papers who describe it to be CMRCP to be very highly specific, as high as 100%. For example, a conventional MRCP over here would let you know and think while evaluating this patient that if this is not taken into consideration, a good anastomosis or hepaticogynostomy would suffice. But a CMRI would tell us that there is a lot of area to be left undrained, and this patient requires 2 anastomoses. Now, to finish in time, I would skip some part of my presentation. It is a word about hepatobiliary scintigraphy. HBS would actually confirm the bile leak. It's a very good investigation. And then it will show us a definite relationship between the leak and any fluid collection over there. Because if it is bile, then you come to know with the HIDA scan, it actually delineates a primary route of bile flow. It provides you functional information once there's an active leak going on. But the thing is, practically very few centers are using it because of the cumbersomeness involvement, where you get MRCP done in minutes. You have to do it over hours, and then this is hepatobiliary scintigraphy, which shows that there's a leak, and with subsequent time the leak is active and it goes and shows you that the whole lot of collection in this area is a bilioma. The shortcoming is that it does not have any spatial resolution. There's no clue about the extrabiliary structures. It has poor sensitivity in patients who have hepatic dysfunction, and once there are large defects, it does not show you the exact site of leak, because it might show you a stump of some sites in the proximal disconnections, but then you don't have exact idea what type of E the injury is, E3, E4, E5. So now what is the need of ERCP and PTC while investigating or these patients? They are both invasive investigations. We all agree about it, and usually should be indicated if it is required for 2-in-1 of therapeutic and diagnostic indications. ERCP might be required in minor injuries when you understand based on your clinical observation of the patients, and if you have proved that these are cystic, this is a cystic duct blowout, the laceration is less than 5 mm, there's a partial clipping. Some good competent endoscopists can bridge a type C right ductal injury, sectoral ductal injury, and all they have to do is they do sphincterotomy and stent placement. A detail of it would be coming up in the next presentation. The PTC may be indicated in some complex injuries where the injury has been neglected for some time. When there is sepsis, cholangitis, and conjugal abscesses, it is preferable to drain both the symptoms if you want to optimize the patient for surgical repair. Coming to the differences of ERCP and MRCP, the ERCP will let you know, if you think about diagnostics with ERCP, then you understand that the bile duct injury is high, but you exactly, MRCP would show you what is happening into the inner ducts. So how to sequence is, once the patient is optimal for repair after CT, drainage of all collection, controlling infection, inflammation, we have to, if we are a proponent of anything early, delayed, late repair, all surgeons would need an exact roadmap, and the proposed, and this can come in the form of the cholangiogram. You have to put up the patient into a classification to plan your treatment while investigating the patient, and sticking to one of the classification to me is actually important. And the ideal classification in acute setting, once a patient has come after injury, would be a Strasberg classification, which is an extension of Bismuth classification. There's a vast variety of classification, and if you want to discuss them while investigating, you need another 20 minutes. So the Strasberg is an easy classification to remember, wherein you have the type A injury, cystic duct stump has given way, or there is a duct of Lischka leaking. These type B injuries are the right sectoral duct or the right posterior duct, which is ligated, and many of these patients might be going unnoticed. Type C is once there is leaky right posterior duct, and type D are those which are lacerations. This might be small hole. When energy source injuries are there, to bigger laceration, but the continuity is maintained. And E1 to E5 are those like that of the bismuth, where E1 is more than 2 centimeter stump, E2 is less. At hilum, it is E3. Beyond hilum, the disconnections are, the disconnected hilum is E4, and a more complex injury is E5. And there are many more modifications. I'll not go into it, but Stewart's Bay classification takes into consideration about the mechanism of the injury. He also puts up a class 1 injury where you have recognized it on the table with a cholangiogram and not much harm is done. The class 2, the continuity is there, and it's almost similar with addition of vascular injury, class 4. Now, this is an important classification which has been put forward by the European Association of the Endoscopic Surgeons, and this is more simple. This might gain popularity and is recommended by World Society of Emergency Surgery to be used in future. They have also, the publishers or the people who have worked on this classification has in their discussion made a mention about Professor Kapoor's editorial in a paper in a journal, where he has actually proposed a similar kind in his discussion classification, where the abbreviations are little different once they published this paper. So it takes into the account the anatomy, the time of referral, and the mechanism, with very simple things like the occlusion is complete or partial, the main pancreatic duct injuries, there are no non-main pancreatic duct is divided, and then the vasculobiliary with abbreviations of which vessel, and the timing of the injury, whether it's an intra-op or the early post-op or the late post-op. And there are many subset of patients who do come late post-op and there's already a stricture set in, and the mechanism of injury. So to put it up in one slide, on receiving the patient, we have to do an ultrasound, LFT, baseline investigation, other relevant blood investigation like CRP, PCT, blood and bile culture of aspirate. In unstable patients, subsequently, you should go first for a CT scan, a CT angio, if your radiologist is available. And it's good that you do it in presence and you don't give two contrasts to single patient and read it retrospectively. You should do then dependingly in this patient, there would be a call taken for damage control or the need of ERCP, PTC, or percutaneous drainage in stable patients, or the patients after stabilizing or before anticipating or contemplating a surgery. You have to do an MRCP, a CMRCP, or HPS, and take a call for subsequent management in minor injuries, the therapeutic. Minor and major means you should be knowing exactly the type of injury where a therapeutic ERCP can be done. In more complex injury, a more delayed approach is probably agreed upon by most of us. And in cases of patient stable non-complex injury, an early repair, which is proposed by many of it, can come in. To discuss a few case scenario, a simple injury blown out in this patient, who is 45-year-old lady, who presented to a surgeon for only biliary colics. She underwent colic lap chole. Drain output was 400 cc on first post-op. She stayed in hospital up to 15 post-op without any investigation. The drain coming down to 50 ml. He removed the drain and discharged the patient, only to readmit on third day with features of peritonitis and collection. And then on dates are important. On 17th March, the patient is operated. On 12th April, she undergoes laparoscopic lavage. And then on 4th May, the drain is still persistent. The patient is referred to SCIMS, to our department in particular. And the patient had 40 cc collection on ultrasound, which was aspirated despite of the drain. We did an MRCP to find out that there was nothing but a little muck reported in the distal part of the CBD, and ERCP clearance was done with sphincterotomy. And this patient took 2 months otherwise and settled with us in another 5 days. So another scenario is a total transection where 24-year-old lady in a remote village in a private hospital underwent cholecystectomy on 10th of December. And she came to us and saying that despite of recurrent visit to the concerned doctor, she was not that sick, but she had pain, abdomen, and fever on and off. After a period of 3 weeks, we saw that ultrasound was showing a large collection. We admitted the patient and did a CCT first, pigtail drainage of the collection, made the collections into controlled fistula, and discharged her to plan a surgery, after MRCP dated. On MRCP again, we saw that there was a small collection. We still decided to wait. And then subsequently, a patient had a definitive surgery on 15th March. This is how the MRCP of this patient looked like. The hilum was intact. There was a suspicion of a small fistula connecting to the duodenum, which was actually there, which was taken down, and a big hepaticoagulopathy was performed on this patient. Another scenario is that a patient who presented with the peritonitis to us. He was a 32-year-old male post-cholecystectomy, not post-cholecystectomy. During laparoscopic cholecystectomy, they actually picked up the bile duct injury intraoperatively, whether they consulted somebody and under guidance, they did a loop hepaticojejunostomy, which seems to be not an appropriate guidance for doing a loop hepaticojejunostomy. And first post-op day, the patient had a lot of bile coming through the drain, which was a big drain placed. The patient was referred on fourth post-op in a sick situation with features of peritonitis and hypotension. He was resuscitated. And what we did is we did not investigate much. We took the patient straight away for surgery. We took down the hepaticojejunostomy, repaired the jejunum. There was a lot of edema and inflammation. So we added a feeding jejunostomy, and we actually put in a tube into the system because the stump was good and the dissection was thought to be, we won't be harming much. And this patient, then on subsequent cholangiogram, this was the picture. And once we thought that we have adequate length, after some time, after everything settled down, another 6 weeks, we called him back and did a repair. Now, this is another patient, a young female who presented to us with intraoperatively again diagnosed bile duct injury, lab converted open to do nothing. They left a drain. And this patient came to emergency, did not report to our department. On ultrasound, they picked up ATCC collection. Then a CT confirmed same, a pigtail was placed, the drain was not draining, was removed. She was planned an MRCP and discharged. But subsequently, she was planned an MRCP, but in hospital, she developed COVID infection. Due to this COVID infection from emergency, she says she was discharged and was asked to report after 6 weeks. She was lost to follow-up, and she came to our department only after 6 months with jaundice, but luckily she did not have any cholangitis. We thought of doing a fibroscan in this patient, besides all investigations, and we saw that the already deteriorating score of 37 had set in. This patient had delayed the surgery for quite some time. After August, the injury occurred. In March, next day, she underwent Roux-en-Y hepaticojejunostomy. We labeled it as type 4 injury, both based on her MRCP as well as the operative findings. This looked like a disconnected system. On table also, there was a septum in between. And we tried to put, once it is on beyond the hilum, then it is difficult to put the anastomosis together. And some of the patients who have a clipped injury go into rapidly progressing cholestasis, and they have PTC being done first. So these are the instances how the clinical presentation of the patient takes a lead. The stump is big, and this is a little older patient. Before the concept of doing and luring out the vascular injury in all patients, I still feel that we don't have to do much for the vascular injury. And this patient could have enough length to open up the duct proximal to the clip. And we have seen, I've gone through the literature also, there's a little second peak in occurrence of bile duct injuries. Initial days, we had worked a lot about bile duct injuries, and the incidence was high. There was a decline in bile duct injury cases in our hospital. And then in 2022, we had a surge. So we went back to look into what is going wrong in these patients, and why did we have an abrupt rise from 5 to 11 cases reported in 2022. And 23, again, with our efforts, it came down to 6 cases referred to us. The maximum injuries were from the particular district. Most of the patients presented within were referred, and they have good knowledge of referral of the patients. We also saw that the at presentation, the patient had peritonitis in 13%, and there were multiple intra-abdominal collections. Bilioma per se were in 33%, and there was some amount of jaundice present at admission, at least in 64, though the highest presenting symptom was jaundice, and a pain followed by pain abdomen. Cholangitis was seen in 20%, where there was already stricturing occurring. And we did not have any type B injury picked up. Maybe they were not referred, and because of no symptoms. And the maximum number of patients were type D, and the most were type D and type E1. Now coming to the management, Early management included exploration lavage in 21%, pigtail drainage in 47%. This developed over a time. Initially people were reluctant in draining the collections. Then ERCP and stenting was required in 28% of the injuries, and Roux-en-Y hepatico-jejunostomy was performed in 71%, of which 2 were done for right ductal injuries. The post-op complications were maximum were surgical site infection, and the bile leaks occurred in 5%.
I think you can
Yeah,
touch
I'll
on
just, yeah, it's yeah. So one important thing I'll just highlight that is the post-op follow-up, a long-term follow-up. We saw that edge stricture was seen in almost 19% of the patients. And to summarize, this is just a last slide. Post-operatively, in cases of suspected bile duct injuries, fistula leak, you should think and take it as a serious emergency. Early and appropriate investigations are key to proper management, as some patients may qualify early repair as well. It is important to sequence the imaging appropriately to address this emergency. CT scan is recommended to be performed early and in most of the cases, it should be done, especially in complex injuries. Proper planning with CT angio may be crucial. Mapping of biliary tract and exact location of the injury for classification grading, MRCP and CE-MRCP are gold standard. Delayed repair, a remapping with MRCP after maturation of the stricture may be necessary. ERCP is likely to be a single station approach for the injuries which qualify for ERCP treatment. PTC may be required in very small subset of patients with cholangitis. So perfectly classifying the injury with judicious use of investigation can give better outcome in hands of experienced hepatobiliary surgeons in this disaster. Debating about timing and all those things are of less importance, but I'd like to make a point that we need to weigh between delay for control of infection and investigation to a prolonged delay when there'll be a stricture would be very bad and cirrhosis is already there. So time since injury, clinical presentation, findings on CT and MRCP is going to guide us to appropriate treatment and tailoring in each patient as required. Thank you very much.
Yeah, I think I'll make 2 quick points, since the emphasis is basically on investigations when you find bile in the post-operative, in the drain, like what exactly you do and how do you proceed. Ultrasound, many of us would say it's ultrasound, but my personal feeling is ultrasound is very unreliable at this stage. And if you are shifting the patient to radiologist suite, you might as well do a better imaging study on this patient, be it, again, whether MRCP or CT scan. Personally, I would go in favor of MRCP because that will tell me the biliary anatomy as well as also confirm if there is any collection and where the collections are located. Though it is said that this imaging may not be very good, particular imaging of the biliary tree in presence of collection, but somehow you would be able to make out what exactly is the type of injury. It may not be very good, but yet you can make a fair impression on the type of injury. So my choice would be for MRC and MRCP rather than CT scan at this stage. And ultrasound, obviously, I just roll it out. It's probably of no good in the post-operative period, in the post-operative abdomen. And having said that, a word about this biliary scintigraphy. This investigation may not be available in most of the places, but where it is available, certainly this is a very good, reliable investigation, particularly at this early stage of bile leak. Just to cite an example, day before yesterday, we did a difficult cholecystectomy. It was a gangrenous cholecystitis. The cystic duct was unhealthy. So yesterday in the morning round, I found there is a lot of this thing in the collection in the drain bag. So I was not very sure. My resident said, sir, it looks like it's bile tinged. But I thought there's a lot of hemolyzed blood and that may be giving some kind of impression of, this bile tinging and all that. So under the circumstances, patient was absolutely stable, no tachycardia, abdomen was soft. So there was no really, pressing the panic button. Yet you need to decide whether there is a real bile leak or not, because your subsequent management would proceed accordingly. So at this stage, to settle whether if there is bile leak or not, biliary scintigraphy is a very reliable investigation. This would definitely confirm whether there is a bile leak or not, which MRCP may not do because MRCP is not a dynamic study, but scintigraphy is. So you can settle this question whether there is a bile leak or not. And if there is a bile leak, whether the bile duct continuity is maintained or not, because you can see the isotope in the duodenum, that would confirm that the bile leak is bile duct is intact. So, there is probably you would think there is probably a bile, minor bile leak. And if at all it is leaking, whether it is leaking out completely or it is going and collecting in the abdomen, in the pelvis, that also impression you would get on the scintigraphy. So where this facility is available, I would certainly fall back on this test, particularly to settle some of these, difficult questions in the early post-operative period. Thank you.
Thank you.
Anu?
Sir,
Yeah.
to add to what Dr. Abrar was saying about scintigraphy, especially in a patient who doesn't have a drain and you have a suspicion, because of its extreme sensitivity, it's a very good investigation. And if you remember, like earlier, we used to do a lot of these scans to determine whether there was continuity. But if there is a large fistula, many a times, even if continuity is there, all the dye
Selectively
goes to the
get
bag,
drained
and
out and
so we stopped doing it because many a times it didn't really pick up, because if it's a large fistula, it goes preferentially to the bag. And about the MRCP, in the acute situation, if our aim is to control sepsis and drain all collections, I mean, I still go towards CT and MR in presence of large biliomas. Many a times the information about the biliary tract and the kind of injury that we are trying to do, that we don't get. So I'm not a big fan of doing MRCP in the acute condition, a lot of collections there. Later on, of course, when you're doing the elective surgery, it is the roadmap which is required. After having drained collections, and if there is a thing that there might be some continuity, like, my residents will sometimes say, the patient is passing colic stools, there is still a fistula, do we need to do an ERCP to stent? Then at that stage, once all collections have been drained, I might do an MRCP just before ERCP to see that there is continuity.
So just a few points. One is LFT. Some people do a routine LFT on day 1 after lap chole. If it shows some derangement, again, it raises an alarm, but a normal LFT doesn't rule out a bile leak. Second, ultrasound. Obviously, ultrasound is the first investigation. But if it shows a collection, it is there. If it doesn't show a collection, it doesn't mean that there is no collection.
No, it's still there.
So if ultrasound doesn't show a collection, but you have a suspicion that there is something wrong, please don't stop at that. Go ahead and do a cross-sectional imaging. Now, between CT and MRI, points have already been mentioned. One advantage of CT scan is that if you give oral and rectal contrast also, which you should, you would not miss a duodenal or a colonic injury, which can manifest the same way as a bile leak. And I'm sure all of us have had instances where initial suspicion was a bile leak, but it turned out to be a duodenal or a colonic injury. The problem with MRI is that if there is a biloma, it will obscure. So MRI is good to detect a biloma, but to delineate the anatomy, the collection either has to be drained or you need to rotate the image in different directions on the screen and see. Because the advantage of MRI is that it tells you about biliary ductal continuity, which some endoscopists want before they go ahead. I think Abhinav will cover this point when he makes his presentation. The only situation where you should probably go for direct ERCP without an CT or MRCP is when you suspect that the problem is because of a retained or a slipped CBD stone. So that is the situation where pain is the predominant symptom. Patient has undue pain, but features of sepsis are not there. Features of infection are not there. And retrospectively, when you look at the ultrasound or the operative findings, you had multiple small stones in the gallbladder, a wide cystic duct, where there is a possibility that during your manipulation of the gallbladder, a stone may have slipped down, which one, it would cause pain. Second, it can cause a cystic duct blowout also. That is one situation where ERCP, an early ERCP would be very, very useful. Scintigraphy, over the years, I have found that, and I have now changed my opinion, that scintigraphy is a good investigation if you want to rule out a bile leak. So if your suspicion is low, the situation which Dr. Ibrar described, and I distinctly remember 2 cases where we knew that it is not bile leak, but the patient was not well. So we got a scintigraphy done, which showed that there is no extra biliary activity. And then we found that the patient was not well because of some other reasons. In one case, it was viral hepatitis. In another case, it was a precipitation of a leukemia, acute leukemic crisis, because of which the patient was not well. So scintigraphy is good because if you don't see any activity outside the biliary, there is no bile leak. It is something else which is happening inside. So these are few points which I wanted to make. And again, those who are watching, students and practicing surgeons especially, and those who will watch these videos, we have covered extensively about bile duct injury in these 2 days, but still, if you want to read more about bile duct injury, please send me a mail, vkkapoor.india@gmail.com. Just write BDI in the subject of the mail.
Sir,
Please
I
get
have a question like to Dr. Sadaf and the other panelists. Would you say there is any role for a re-laparoscopy if you're suspecting a bile leak?
Yeah, I actually went into looking for a re-laparoscopy or diagnostic role of laparoscopy in bile injury. There isn't much thing covering up, but there is a possibility that if the surgeon has a strong idea that there is no bile duct, injury committed, then in younger patients, it's not an option in all patients, like high risk patients, and it needs general anesthesia. So there is an I should say that I don't have an appropriate answer for that, but I thought about a similar question and tried to look for role of diagnostic laparoscopy. And there are people who have written a case report or two picking up only laparoscopy and giving a peritoneal lavage. But as such, there isn't much mentioned in the consensus guidelines.
I would say that at a place where the other investigational facilities are not easily available, there are logistics or costs issues. In the early postoperative period, day 1 or day 2, if the patient is otherwise fit for an anesthesia, I would suggest that it should be kept as an option rather than doing nothing.
I would do re-laparoscopy not to correct any injury or the bile leak or anything, but to drain out any undrained collections. Because when there are diffuse collections in the pelvis, in the abdomen, and all that, radiological drainage is not an answer. There you have to do a re-laparoscopy and drain out all these quadrants. I mean, look at that and then drain out all those. And any attempt to control the cystic duct and all that is obviously not the approach here. Or should not be attempted. Whole idea
Sadiq,
is
you
only
want
to
to say
drain the
something?
collections.
We have
Yes.
2 more minutes for this session. Sadiq.
So I need to defend Ibrar in this. See, I mean, we are talking about CT, MR. The bottom line is, if you're looking for collections with equal sensitivity, you will get on MR, the collections. And you may get additional information on bile duct. As you say, if you work on the workstation, you will be able to get information about the bile duct. So a single investigation would be a MR, which will give also the location and the number of collections. The only problem is CT is much quicker. In a patient who is sick, they are able to undergo a CT scan more conveniently, as opposed to an MR, which takes time, and it takes at least a half an hour before we do an MR. So in that context, it may not be the most appropriate in a sick patient. The other thing about laparoscopy is, a lot of times we've grown up looking at doing percutaneous drainage and multiple drainages, but the radiological drainage is not always adequate. And if you need to do multi-quadrant drainage, then I think a laparoscopy and drainage of all collections and placement of good drains in the subhepatic space may be an option when you are dealing with bile leak and bile collection, bile peritonitis, and situations like that.
So would you take time into consideration, like time after injury, like because patients are referred at various time intervals, like about this re-laparoscopy?
So see, Anu, it is in context of draining all collections. So irrespective of any time, when the patient presents. Say there are 2 or 3 collections, subdiaphragmatic, subhepatic, and then there is one in the pelvis. And you're going to put 2 or 3 drains. But by laparoscopy, you would be able to drain all of these and would target the subhepatic area to place your drains. So I think it's a underestimated uh, uh, kind of intervention, which is not much harmful, but at least it gives an opportunity to completely clean the peritoneal cavity and collection. And generally, when we have explored these patients, there's a lot of debris and all also present in this. And these we can evacuate by a good laparoscopy lavage as opposed to a pigtail drainage. I
So
think.
actually, I asked this because, supposing a surgeon has done a lab call in a nursing home, and like if these are kind of guidelines, then, if they have to tell the patient, okay, I have to take you to the operating theater again, give another anesthesia and do. So these thoughts also come to my mind when we think of re-laparoscopy and like.
So we can't always think in terms of what somebody else would do. It's a question of, you have X number of options. You have to judiciously use them depending on where it is, what you intend to achieve by that. And over a period of time, at least I have realized that it's a very good intervention in early and in multiple collections. It is more reliable than placing multiple drains.
I
But
agree. So the
that
multiple
doesn't mean that
corrections.
each time I would always do it. You would still decide in each individual patient that what kind of intervention is required. And one more point which I want to add in investigation, which we mentioned, but I want to emphasize again and again, is getting adequate information from the uh, place where the injury has happened is important. And of course, if recording. So we need to emphasize on people that, if there is a difficult uh, situation they are encountering, difficult cholecystectomy, they should record that. And nowadays, I don't think it is difficult to have a recording of a procedure. So if they record it, it's good for them because the referral would be good, their patients would be benefited. And if you see a recording of a cholecystectomy, your perception of the whole procedure would be different, and your approach may change based on what you see at that point of time. I think that's an important, I would put it as an investigation which you should look at in the immediate period when the patient is referred.
I think we need to move on. So I'll introduce the next speaker and then hand over to Ibrar and Anu. Dr. Abhinav Sharma is one of the senior gastroenterologists in Jaipur. He is again an SGPGI alumnus, and I'm thankful to him that he accepted my invitation and request to join this discussion. Ibrar.
Yeah, over to you, Abhinav. I think we have had enough discussions. Let's listen to him first, and then we can discuss.
Thanks for kind invitation to deliver this talk on bile leak when to do ERCP. So are my slides visible?
Yes, yes.
Yeah, it's
Just make it full screen, please. Yeah,
Yes.
it's okay. Good.
So I think my job has also already been made easy by Dr. Sadaf, and this is the key slide. This is basically from an abstract endoscopic management of post-cholecystectomy biliary leak, when and how. So modalities are sphincterotomy, biliary stent, and the timings on the right side of the screen timings have been given. Now, this is a complex team approach when a patient has post-cholecystectomy bile leak. We need biliary endoscopist, intervention radiologist, and most importantly, hepatobiliary surgeon, which is the key person. So, the injury may happen to cystic duct remnant or gallbladder bed or accessory duct, or there may be lateral injury to bile duct or common hepatic duct, or there may be circumferential injury. And as Dr. Sadaf has already laid out, there are various classification systems, and the most recent is atom classification. But we are more familiar with Strasberg because we have been managing these patients using this classification. So these are the types, 5 major types of Strasberg classification, type A to E. is in these three types of injuries, type A, type C, and type D, where there is a injury and leakage. Circumferential injuries, which is type E injuries, are difficult to manage because guide wire will not cross if we pass guide wire through the papilla, and there is circumferential injury, so it is not possible to pass guide wire up. So hence the endoscopic management is not possible in these patients. Now, these are some examples of biliary injury. The first panel on left shows bile leak from cystic duct, and there are retained stones. And this is the very case which Dr. Kapoor had just highlighted. It is the indication of ERCP because we have to bypass the leaking duct using a stent, and we have to remove all these stones. And indications become more urgent if the patient has associated cholangitis. And this patient typically presents with pain and jaundice along with presence of biloma. Now, the second and third panel, they are types C injuries, bile leak from peripheral duct, and you can see a collection there. And in the second page, the third panel, again, there is a demonstration of bile leak from a peripheral duct into the postoperative bed. And in the CT, you can see small collection there. This is the circumferential injury, Strasberg type E injury, where you can see the confluence is patent, but there is no opacification of distal ducts beyond confluence on percutaneous cholangiogram. So this is not amenable with ERCP. This picture shows that this large segment of CBD is missing, and you can see a T2 attempt has been. ERCP in the algorithm of bile duct injury, you can see it there. It is very much there if a patient has basically bile leak, and if there are signs and symptoms, there is jaundice. So jaundice entails that there is a basically occlusion of bile duct, and you do a cross-sectional imaging MRCP, if you find that if there is a obstruction to biliary system and there is no circumferential injury, that is, there is no clip on the CBD, and if it is possible to bypass guide wire, then you go in ERCP. So this is the algorithm. I won't go through that because this is not required here. And these are I'm just straightway coming to the success rates of ERCP, and it is very good. Various studies. This is a synopsis, and approximately 90 to 95% cases there is a clinical success if we do ERCP with or without a stent. So this is a famous Dr. Sandaj study where around 207 patients, he attempted to classify them into low-grade and high-grade leak. If a leak is visible only after opacification of intrahepatic biliary radical, that is, if leak requires enough pressure to be generated to manifest it is low-grade leak. And if even before opacification of intrahepatic biliary radical, you see a leak, it is a high-grade leak. Means you don't even require to generate much pressure to opacify intrahepatic biliary radical, and you see a leak, it is a high-grade leak. And the author went on to suggest that for low-grade leak, only sphincterotomy is sufficient, and for high-grade leak requires a stent. But this was challenged with subsequent studies. These are three alone is sufficient, or whether a stent is required. And these studies demonstrated that if you put a stent along with the sphincterotomy, the success rate improves, and there is the resolution of bile leak is also quicker. So nowadays, dictum is you do sphincterotomy, but you also put a stent irrespective of grade of leak. Now coming to timing of ERCP, which is my topic, there is positive data. There is no meta-analysis, and a number of studies are limited. So I will quote whatever studies are available one by one. This study is from USA, around 500 patients, post-cholecystectomy leak in 70%, and this was retrospective data collection. They divided these patients according to the timing of ERCP, less than 1 day, 2 to 3 days, more than 3 days. And what they saw was there is hardly any difference as it is with respect to outcome, that is resolution of leak. there was no statistical significant difference. So irrespective of timing, whenever you do ERCP, whether you do day 1 or 2 to 3 or after 3 days, the results is same. Or most of the patients, they have resolution of leak and there is no significant difference. When it comes to adverse event complications and death, again, the data says this says that the difference is not very statistically significant. So timing of ERCP doesn't matter with respect to adverse event and with respect to resolution of leak as far as this study goes. The second study is again from double the number than previous study, and post ERCP therapy for post bile duct injury post cholecystectomy patients. So all of the patients who had undergone cholecystectomy landed with bile duct leak, and in this study they defined these time intervals. Less than 1 day they called emergent, 2 to 3 days called urgent ERCP, and after 3 days they call expectant ERCP. So they try to define these time intervals. And this is the result. The orange bars, they show basically post-ERCP adverse events, and the blue bars, they show in-hospital mortality. As far as adverse events are concerned, the adverse events were not different in any of the group, whether you do early ERCP or late ERCP. And mortality, there was a trend of high mortality in the urgent ERCP group. So conclusion of the authors were that the timing of post ERCP endoscopic therapy, whether urgent, emergent, or expectant, that is basically predictor of mortality, but not the post-operative adverse event, post-ERCP adverse event. This is another study, a large number of patients, again a retrospective database, again from USA. Of 200 patients, around 600 underwent ERCP, post-operative bile leak. Again, the same the division of time interval are emergent, urgent, and expectant. So in this study, they defined adverse event if they were related to either anesthesia or a blood loss, that is transfusion, or if prolonged ICU care is required, or and complications, ERCP complications, they defined by pancreatitis, cholecystitis, duodenal perforation, duodenal hemorrhage. So these are the results. You can see the three bars here, blue, orange, and green. These basically denote emergent, urgent, and expectant time intervals. And you can see in first panel adverse event, ERCP complications, and hospitalization. And in adverse event, there is significant difference if whether ERCP is done early and expectant the better. Again, rehospitalization, expectant is the better. ERCP complications, no significant difference. Then they try to basically do subgroup analysis as far as cause is concerned. Post-ERCP, post-cholecystectomy bile leak and ERCP done, or post-traumatic bile leak and ERCP done. Again, there was trend that expectant treatment is better in terms of complications and adverse events. So this is the conclusion of the author, that bile duct injury patient who underwent expectant, means delayed ERCP, had lower risk of adverse event. And if we do emergent ERCP, then there is higher risk of pancreatitis. So it is this study shows that there is a point in delaying ERCP till the patient settles down. But one caveat here, which is to be highlighted, that this study and other studies may be subject to basically what we call bias, which is emergency bias. Means more serious patient will be taken up before ERCP early. And since they are already serious, so there will be high chances of mortality and adverse event there. So this is emergency bias which this study might be subjected to. KEM hospital, where they tried to look into emergent, urgent, and expectant treatment in bile leak, but the rate of complication is very low, sample size is low, so there cannot be any conclusion drawn from this study with respect to timing of ERCP, whether it is better or not good. So this is my last slide. There is a positive data on timing of ERCP in bile duct injury by leak. Most of the data which is there is retrospective and is subject to selection bias. In all of these studies, ERCP timing has been divided into emergent, urgent, and expectant, less than 1 day, 2 to 3 days, more than 3 days. There is no difference in clinical success based on timing of ERCP. But expected ERCP, that means delayed ERCP after 3 days after stabilization of the patient, has less adverse event, and most often they recommend now that ERCP should be done after 72 hours in case of bile duct injury. Thank you, sir.
Ibrar, Anu.
Yeah, I think you have covered all, but I think I'll make a quick point that from practice point of view or for clinical, I mean, from day-to-day practice point of view, I would say that the definite indications of ERCP, one, when I'm suspecting there is a residual stone in the CBD and that has caused bile leak, then obviously I'll definitely refer the patient to you and get a ERCP and stenting done, stone clearance plus minus, depending on what kind of stone is there. But certainly I'll do a sphincterotomy. I'm going to ask for a sphincterotomy and stenting in these patients. Number two, that subtotal cholecystectomy or an unhealthy cystic duct, and if I find bile, I know my CBD is intact, yet to control this bile leak, and if it is significant, I'll certainly refer this patient for ERCP. And of course, cystic duct blowout, occasionally, if the bile leak is continuing and it is significant, and that is one indication where I would refer the patient for ERCP. Emergency ERCP per se, I don't think there is any role in the surgical practice. All this ERCP can be properly planned and timed. Thank you.
Emergency ERCP is only required when there is, as Dr. Kapoor already said, there is a stone sitting up at lower end of CBD and then cystic duct blowout, or if you suspect that it is cholangitis, which is cause of the symptoms and worsening to the patient.
Right.
And Dr. Abhinav, is there any role for an ENBD instead of a stent that later on you can do a cholangiogram, see whether when the leak has subsided, you take it out and you don't have to do a repeat procedure? Is there any role?
Yeah, ENBD is a good idea if you want to plan later on cholangiogram. But the problem with ENBD is it is number one, uncomfortable for the patient. And number two, those cases where ERCP is required, stent does the job. Basically, in type A injury or type C or D injury, usually subsequent cholangiograms are not required. And this stent you are going to leave for 4 to 6 weeks. So when you remove the stent at that time we do endoscopic cholangiogram already.
So from a clinical practice point of view, I would say there are two schools of thought. One is an aggressive group where the moment you see bile in the drain or you have a biloma, you have placed a PCD, I would go for an ERCP. And this would be if you have excellent endoscopy support where you know that the complications of endoscopy are low, it would definitely heal many of the leaks like cystic duct or a cholecystohepatic duct, which is in continuity with the main system, a side hole in the CBD. It would definitely reduce the duration of the bile fistula and hasten the closure of the fistula. On the other hand, there is a conservative school of thought where if I see bile in the drain and if the patient has no sepsis, cholangitis, which requires early or urgent endoscopic intervention, I would probably keep a watch on the clinical condition, the septic status of the patient, and the amount of bile which is coming out. Because if it is a small cholecystohepatic duct, I know that it is going to close spontaneously. Even a cystic duct leak may close spontaneously. So gradually in the next 1, 2, 3 days, the amount of bile may come down, patient remains sepsis free, and then I may not go for endoscopic intervention. So these are two extremes. In real life, depending on the patient's septic status and the amount of bile, you decide. Definitely, there is no doubt that if there is a bile leak from a duct which is in communication with the system, the endoscopic intervention is going to help. One word of caution: if you have bile in the drain, you have done endoscopic papillotomy and placed a stent, and still the bile continues to remain the same, that is the time, if at the time of ERCP you did not suspect that it is an aberrant isolated duct, you have to suspect that. And that is why, if you are doing cholangiogram, whether it is MR cholangiogram or ER cholangiogram, you must try to visualize all segmental ducts. If some segments are not seen, again, you should start thinking of that it is an aberrant duct, because in that situation, in an isolated injury, the ERCP will not help. The leak from the CBD side of the divided duct may stop, but the leak from the hepatic side of the aberrant duct will continue to be there. And this point which Anu raised, in some cases, I also thought initially that if you think that it is a small duct in continuity with the system, where you expect that after endoscopic intervention, the leak will stop in a few days' time, and you don't anticipate a stricture forming in the main duct, whether an ENBD, although it is uncomfortable to the patient, is a better option, because then you, as soon as in a few days' time the leak stops, you just do a ENBD cholangiogram and you pull it out. You don't need another endoscopy. But I suppose the trend these days is to place a stent, which definitely takes care of a side hole of the CBD much better than an ENBD will.
There is one more situation where I would want to combine ERCP with the surgical procedure is re-laparoscopy. Because under anesthesia, if you're doing re-laparoscopy to drain out all the collections, I would rather choose to do a ERCP and stent the CBD, provided I know the CBD is intact. Then I do ERCP and stent the CBD in the same setting, so as to minimize the leak and get the maximum benefit of the drainage that I have achieved by doing re-laparoscopy.
We have two comments on the previous sessions in the chat, which Himanshi has sent me. Dr. Ankit Sharma wanted to know what is the incidence of bile duct injury the panelists have had in the cases operated by them. So I will take that question first. I can't, Ankit, I can't give you the exact incidence, but I think there would hardly be any surgeon who can say that I have done enough cholecystectomies and I haven't had a bile leak or a bile duct injury. At least I have had. So, and when we did the survey, which I read out yesterday, 86% of the surgeons who responded to the survey accepted that they have had at least one, and more than 70% said they have had at least two bile duct injuries. Abhinav, you wanted to add something?
I think you or Dr. Sadiq used to say that there are two types of surgeons in the world: one who has done bile duct injury and one who will do bile duct injury.
Going to do. Yeah. The second is a comment by Dr. Mathur. Actually, he joined on the YouTube. I requested him just now to join on the Zoom, but he has agreed with Sadiq about the use of laparoscopic lavage option whenever there are multiple collections or generalized peritonitis. I think that point has already been emphasized, and Dr. Mathur just wants to say that. Yes, Ibrar.
No, sir.
Okay. So since we have a few minutes, TD is there. TD was the moderator yesterday. TD, you want to add anything to any of the topics covered today? Dr.
Sir, I was in OT, so I could not hear most of the thing, but Dr. Abhinav, I did listen. Just I joined, I have just reached home and joined. So every time we are seeing these patients and in PGI, what I am seeing that most of the patients, they come after either done ERCP or attempt of ERCP, whether there is a continuity or not. And that is a very disappointing situation. So I think message to you from your side should go very clearly to the people listening that when there is a bile duct injury, our first aim is to make a control fistula. By doing, you do PTB, percutaneous drainage, or you do laparoscopic lavage if required. If not laparoscopy, you can even do a proper lavage and make a one or two tubes and make a control fistula. And then one should start thinking whether there is a continuity or not. So we are religiously doing not the MR in the beginning, but definitely we are doing HIDA scan. And as we know that isotope sensitivity is too high, and if we are finding any amount of isotope entering the intestine, Then we either we go for MRCP after controlling some, or we request our people to look into that. If not, 100% cutoff is there, then probably we are very much scared, because we are having lots of problem because of the repeated attempt of the ERCP, and probably this is a pressure from the surgeon side. So every surgeon wants as we discussed yesterday, not because they want to hide anything, but this is a pressure from every side, and they want to get rid of the thing without getting surgery done. Second surgery, for the surgeon, it looks like that he failed and somebody else is taking care of that. I think these are some important points. There is a pressure, but at the end, as we discussed yesterday, that one has to accept, and these are the basic principles. 3 bile duct injury we have in the ward right now, and every patient has been ERCP attempted. Very sick. One of the Mataji is very sick, but not that we are we are not criticizing anybody. But I think endoscopic ERCP over attempt is being made, and that probably message has to go. Nothing against anybody. This is a very situation where it is because of everybody wanting, and everybody wants to get things done without surgery. So this would be my comment, that we should be little bit more careful. Any bile leak every time, I think ERCP is a disaster to my mind. Thank you, sir.
Actually, what TD is saying is right. It's a reflex response of the surgeon. As soon as there is bile in the drain, they think of an endoscopic intervention. But we all have to remember that the first aim of a bile leak is to drain the bile from the peritoneal cavity. That is what is going to kill the patient. That unfortunately is not looked for and is not done. And we also have seen patients where endoscopic stent intervention, whether successful or not, has been done, but still there is bile in the peritoneal cavity. So that is the first thing. So first is to look for bile, drain the bile. Then comes, and as was presented very well, supported by data by Abhinav and commented by Ibrar also, there is very little indication of an emergent or an urgent endoscopy. In post-cholecystectomy situation, usually it is a planned intervention. And before that, bile in the peritoneal cavity must be drained. And as I mentioned, that if the patient is not in sepsis, and if you are observing the patient under your eyes, even if there is bile in the drain, there is no harm, at least in my opinion, in waiting for a day or two to see what is the trend of this bile output, and then decide, then take a call that whether endoscopic intervention is to be done or not. But if you are doing a difficult gallbladder, the point which Dr. Sadiq was mentioning, or as soon as you see bile in the drain, you must definitely send a consultation to your endoscopy colleague so that he or she is on call. Then you are working as a team, and the moment you decide that endoscopic intervention is required, it is done as a planned procedure, not in the middle of the night.
Experience of endoscopy team is also important, because these ERCPs are very complicated ones. Sometimes in lateral injury, the CBD is hanging just by a thread, and negotiating guide wire across that injury is very difficult. So these kind of ERCP, because already there has been a complication, so these ERCP should be done at high volume center, and endoscopy has to be sufficiently experienced in handling these kind of cases. Because you may use another, because early ERCP, we have already seen that there is a high risk of pancreatitis and other complications.
I would suggest that every surgeon who's doing lab chole should have a good endoscopist friend who, as Abhinav said, is experienced in handling these cases. And you should refer these patients. And as we discussed yesterday, it is not that just tell the patient that go to endoscopist. You have to talk to the endoscopist. You have to give him all the findings, what is the current status of the patient, and then send the patient so that the patient is well received and well treated there. Because all these things are very, very important from a medico-legal point of view also. Sadaf, you want to say something?
Yeah, sir, I wanted to make a point here that who should the primary surgeon who has created the injury? Because if you take the scenario of yesterday's discussion, we discussed a lot about, holding on even with the completion of cholecystectomy. So I personally feel that the first person to be approached once an injury has happened by a surgeon who's more of a laparoscopic general surgeon should be a HPV surgeon. And then it should be a team discussion, the way we have tumor board discussions for deciding about what we do about a particular case. And it's not that emergent always. You can take a decision, and if it is required, if the patient qualifies after investigation, then definitely an ERCP can be done wherever indicated. So the first person who decides should be a head of the family, sort of, should be the senior most available. Personally, I feel that it should be HPV surgeon.
Yeah, but Sadaf, I mean, the real life situation is that most cholecystectomies would be done in small nursing homes, small hospitals, periphery, single surgeon, no support available. So that is why I personally feel that we all have a responsibility towards our general surgical colleagues also, as I was saying yesterday, that we need to think of some mechanism where immediate, at least advice is available to them if they run into a problem during cholecystectomy or after cholecystectomy. I have it in mind. I hope that in next few years, I will take it as a mission that we create state-wise, and in each state there is a group of 10 or 15 of us who are on call kind of thing, where the surgeon can talk to us and take an opinion from us as to what to do, and more importantly, what not to do, because that is what creates a problem. Since we have a couple of minutes, just a few points I would like to make about the medico-legal issues related to bile duct injury. There is very little data from India, but whatever data is available from the UK, Europe, and West, the factors which result in a case being filed against the surgeon and then the case being decided against the surgeon are, number one, obviously, if the patient dies, there is no doubt about it. Second, if it requires a repair in the form of a hepaticojejunostomy, and more so if the repair is unsuccessful. Third, a delay in diagnosis, the point which Kailash in his presentation covered, that there are reports that there has been delay of days and even 1 or 2 weeks in suspecting that there is something wrong. And a very important factor emerges, at least from the West, that if the repair is attempted in the injuring hospital by the injuring surgeon, that is a very strong predictor of a case being filed and case being decided against the surgeon. So as I mentioned yesterday, CELSI has produced guidelines for cholecystectomy in which many of us were participants. And now at least the Indian surgeons and those of you who are participating from other countries where there are no national guidelines, you can fall back on these guidelines, saying that CELSI has recommended that if you are not a biliary surgeon, after stabilizing the patient, it is best to refer the patient to a biliary center. Biliary center is a place where facilities and expertise for interventional radiology for draining the bile, facilities and expertise for therapeutic endoscopy for draining the bile duct, and later on, biliary surgery for repair of the biliary injury are available. So if you do that, you can, even if a case is filed against you, you can stand up in the court of law or the consumer forum and say that, look, I did what the guidelines have recommended. And that is what I was supposed to do, rather than trying to do the repair or do the treatment yourself where facilities and expertise is not available. So that is a small comment on medical legal. Sadiq, you want to?
I just want to add on this medical legal because I've gone through a lot of consumer forum reports in India. And the most important reason consistently which has been observed is the delay in diagnosis and not paying attention to. So most cases have patient visiting the surgeon once, twice, but the symptoms are not given importance. And therefore, there is a delay in diagnosis and referral. So I think even here in most of the cases in the consumer forum decided against is because of that. The second thing is documentation. It has been consistently found that there is no documentation, who's doing, what was done, and those things, when they are lacking, it results in, even when the expert evaluates that case, there is no documentation. So there is a high likelihood of, in contrast, those where they are absolved are where there is a good documentation. And there are several cases where they have been absolved. from the fact that it's not negligence, but in that appropriate referral and good documentation has been done. So what points which you identified from the West, if we study the cases here, similar reasons emerge for this litigation.
Abhinav, you wanted to say something.
The delay in diagnosis might be probably due to denial to diagnose. It's
Yeah.
denial that injury has happened.
Like that.
Yeah.
See, as the first case that we presentation, that if you don't pick up subtle points and the patient is kept on saying, I'm not feeling well, and the surgeon says, oh no, everything is okay. But if that ends up having a problem subsequently, that leads to litigation. So you need to pay attention to every small, in these scenarios. So sometimes you may evaluate or go a little overboard in evaluation if the patient is complaining consistently that he or she is not feeling well. So there is no harm in doing the basic set of investigations at least and ensuring that their complaints or what problems they have had been paid attention to. The doctor has seen that and the investigations did not show anything. And that's okay if you do at least that much.
So we still have 3 minutes. Any other panelists, TD? We have Dr. Nabeen Paudyal from Nepal. Dr. Nabeen, you want to make any comment?
So I just want to ask Abhinav.
Yes, sir.
See, we are talking of ERC, and I totally agree with what TD says that irrespective of what we talk about, the practical situation is most of them would have had an attempt or a ERC being done, whatever is the reasons. Now, we talked about when it should be done, and it clearly is a therapeutic intervention rather than a diagnostic. And therefore, you have to have a very strong indicator that it would provide therapeutic benefit. So what you ensure when you take up a patient for ERC, what would you want before that?
Sir, before going ahead with the ERCP, first patient should be able to sustain ERCP. He should not be in septic shock or ARDS. He should be stable enough to withstand ERCP. Number two, indications have to be clear. When indication is absolute indication are number one cholangitis, number two stone in the CBD. These are the two emergent indication where I would even means ongoing stabilization, and with that ongoing stabilization, I would try to drain the bile duct. Other than that, first we have to stabilize, then we have to categorize.
But how would you know there is a stone?
Only if you have done a previous MRCP.
MRCP, medical gastroenterologists nowadays recommended MRCP whenever you call them also.
So that's what I mean, that, you need a certain investigation prior to, that's what I wanted to, get out, that obviously you would need some information that A, there is a lateral leak, B, there is a stone, and that means a MR would be something which you would want before you undertake a ERCP.
Yes.
Am I right?
If cost is not a constraint, then I suppose that should be the sequence.
But if it is a constraint, then you would do a ERC?
Yeah, then it depends, as I said, that whether you have an aggressive or a conservative approach, what does the LFT show, what does the ultrasound show, what is the clinical picture. If you, based on everything, if you suspect that it could be a stone, then definitely an ERCP should be an early intervention. But if you don't think, if it is painless bile leak, patient is not in sepsis, I would probably hold on for a day or two and see what is the trend. So we just have 1 minute. Any concluding remarks from Ibrar or Anu before I close the session? If not, then I would like to thank Ibrar and Anu for moderating today's session, and thank other panelists also for joining, and thanks to the speakers, Sadaf and Abhinav. Special thanks to Abhinav for accepting and for joining on both days, although it was purely a surgical, but I feel that we have to have more and more related specialities into our master classes. Most probably, I'm making a provisional announcement. The next master class will be on ulcerative colitis. So very soon we will inform all the members. And again, I would like to thank my colleague, Dr. Anand Nagar, who's been running the JST so well for last 2.5 years, and to Avinash. Avinash, if you are there, you can come in, who's been providing technical support, and his team of Himanshi and Kripa, who've been providing Zoom links and YouTube links and uploading of the videos. So all videos of all Jaipur surgical tutorial activities are available on YouTube. If you go to YouTube and put Gastro University, that is the website of Avinash, or to the MGMST channel, on both sites, all these videos are available, including the videos of all the 3 Jaipur surgical festivals which have been organized in last 3 years. So with that, at 9:01, I say thanks and good night to everyone, and we will close the session.
Thank you, sir.
You're supposed to have some special comment, you said?
Yes, please come in.
There's some guest speaker from Greece, you said you'd
Oh, no,
have.
he is not logged in. I tried to contact him, but I think he is not logged in. So that is why I did not interrupt in between.
Okay, right.
Okay. Yeah.
Thank you.
Avinash is there. Thank you, Avinash. Thanks to your team, Himanshi and Kripa. Thank you. Thank you very much.
Thank you, sir. Good night.
Thank you, sir.
Good night. Good night, everyone.